Hi, everyone. I'm Gary Bernardini. I am chairman of neurology at New York Presbyterian Queens. And today I'm going to discuss a chapter I co-authored with Ilko Vajic and J.J. Bauman on clinical evaluation of coma and brain death. What I want to do is just go through some key points in this chapter and then sort of address some of the questions that you may have about coma and brain death. I know it's a very broad topic. We tried to address really the key points in terms of the evaluation, your assessment of the cause of coma, which is always key, and as well as the examination, the workup, and treatment. Let's talk first about coma. Coma is defined as a deep state of unconsciousness due to bilateral hemispheric damage, brain stem dysfunction that disrupts the activating reticular system or both. And this is pretty common. So it's either bilateral hemispheric damage or brainstem. There's also the minimal conscious state, another term that describes severely altered consciousness, which is minimal but the definitive behavioral evidence of environmental awareness. So as we go into this, people can go into coma, may go into a vegetative state, which is defined after 10 days of being in a coma. But you could also move into the minimal conscious state. We'll talk a little bit more about this. In general, the thinking about causes of coma, it's either metabolic cause or structural cause. I know it's somewhat simplistic, but this really does hold true. We talk about the anatomy briefly. I know we've all had neuroanatomy, but it's important to know that coma is really due to disruption of the posterior cingulate and precuneus cortex. It also involves the thalamus and connection between the pontine tegmentum, the left insula, and the genu anterior cingulate cortex. So interruption of these pathways will lead to coma. Let's move along. Let's talk about the structural causes of coma. Structural causes usually lead to increased intracranial pressure. It could be trauma, it could be a mass lesion such as a tumor, it could be hemorrhage, it could be stroke. In the process of progressing in structural coma, initially with increased intracranial pressure, I'll just refer to it as ICP, there's initial accommodation with displacement of CSF. There is this Monroe-Kelly doctrine, which says that there's a constant volume of brain CSF and blood. There's some accommodation, like effect or structural cause of coma. But over time, you lose the accommodation, and this is where you see decreased mental status, level of consciousness, decreased heart rate, increased blood pressure, change in respiratory rate, so-called Cushing's response. And then this can progress where you get change in respiratory pattern, going from central neurogenic hyperventilation to apneustic breathing to BIATS to apnea. With continued increased intracranial pressure that's not treated effectively, the end result, which we are all trying to avoid, is brain death. This is complete loss of brainstem function, fixed dilated pupils, irregular breathing pattern, decreased blood pressure, and loss of all brainstem function. Along the way, intracranial pressure monitoring is very key. So whether you put in an external ventricular device or an ICP monitor, we usually prefer the EVD because that allows you to treat the ICP elevated by draining CSF and also monitors ICP. We look for so-called Lundberg waves. These are plateau waves, spikes in ICP, meaning the brain's losing compliance, and these need to be treated. Herniation itself from a structural lesion, there's two types. The somewhat older thinking is central tentorial herniation, first proposed by McNeely and Plum back in the 1950s. And then more recently, C. Miller Fisher, the well-known, internationally known neuropathologist from MGH, along with Alan Roper, come up with an uncal herniation process, which seems to involve and purports more lateral displacement of midbrain and brainstem. And radiologically, this is what you see. You actually see widening of the ipsilateral cistern, contrary to what you might think. But if you do see this, you'll see this on a patient. On the imaging, either CT scan or MRI scan, in the ipsilateral side of the mass lesion, there's actually widening of the cistern. Their theory. We move along to metabolic causes. There's a whole list, as you could imagine, of metabolic causes of coma. And due to the metabolic etiology, these can be reversible. So we're looking at hypoglycemia, organ failure, endocrine causes, intoxication, electrolyte imbalance, infection, inflammation, could be encephalitis, meningitis, neurodegenerative disorders, cofactor deficiencies. Then the probable irreversible, I would say, before the advent of therapeutic hypothermia would be cardiac arrest with hypoxic injury. And I think as more research is being done and we see more of these patients, the tenet that if you have a hypoxic injury from cardiac arrest, that sort of the game is over doesn't really hold. EEG can show status, and yet there are some reports of people recovering from status arrest, but therapeutic hypothermia gives them a much better chance to recover with little or no brain injury post-cardiac arrest. I'm not going to go into the details of therapeutic hypothermia, but that's a treatment for that. Oftentimes with the metabolic causes of coma, it's preceded by delirium. And delirium is not that you're just confused. Delirium is a state where it's characterized by disorientation, reduced attention, disorganized thinking, perceptual disturbances, often delusions or hallucinations. And these may be, and possibly with some dysautonomia. The patient who's delirious may have lucid periods and then they go in and out. So this is often precedes a metabolic cause of coma and should be looked for. If we go to the exam, first of all, before we do that, look at metabolic causes of coma. It's important, as in all causes of coma, to get a history. Neurological exam is very important. We'll get into that in just a minute. Respiratory pattern is important. Pupillary responsiveness, ocular movement, doing oculocephalic and ocular vestibular testing is important. Labs are important to help rule out a reversible cause of coma. Neuroimaging is key. CT scan, very sensitive for hemorrhage, not so sensitive for ischemic stroke. You can certainly see masses even without contrast on a non-contrast CAT scan. MRI, though, is really very sensitive for picking up lesions. Could be anything. Could be mets, could be subdural, could be hemorrhage, could be tumor. And then EEG is also important. EEG and the metabolic cause of coma, as we all know, shows a non-specific slowing. But you get more focal abnormalities in EEG with structural lesions as a cause of coma. When we look at the exam, if we go top to bottom for neurological exam, pupillary responsiveness is really the most important part of the neurological exam to distinguish between structural and metabolic causes. Preservation of the pupillary light reflex despite respiratory depression, extensor rigidity, motor plasticity suggest metabolic coma. And roving eye movements are commonly seen. Eyes just going from side to side are often associated with metabolic cause and not a true structural lesion. Look at the wide range of on the respiratory pattern. We can see initially you can certainly get Cheyne-Stokes respiration, which is a crescendo decrescendo respiratory pattern. And if you're on service and you're either an attending or a resident, you probably ask what are the causes of Cheyne-Stokes. One is certainly hemispheric, oftentimes bilateral hemispheric damage, but then CHF can cause Cheyne-Stokes. It has really nothing to do with brain injury. But Cheyne-Stokes crescendo, decrescendo, and somewhat prolonged apneic periods for several seconds. So you may be called by the nurse. The patient to stop breathing intermittently, and you go and you do the exam at bedside and they have Cheyne-Stokes. Not really too well localizing. We get into hyperventilation. That could be either from hypoglycemia or anoxic brain injury, hepatic encephalopathy, or again, a lung process. But then when you come down to apneustic breathing, which is called square wave breathing, that changes and you have a brain lesion. And then Biot's breathing is as that wave of pressure goes down to the lower parts of the brainstem. Biot's is very irregular, followed by apnea. There's a wide range of motor exam findings. Certainly tremor, asterixis, myoclonus seem to be seen with metabolic derangements. And extensor posturing, both extensor and flexor posturing is a sign of brain stem injury. And when we get to brain death, you cannot have either either posturing is not consistent with brain death. Again, EEG, I mentioned, could be very beneficial. If we look at the doll's eyes maneuver and the oculovestibular, is very important. So doll's eyes can go with the metabolic process as well. It's really pupillary responsiveness. Obviously, we do have structural cause of the coma, and there's increased ICP over time. You will get an irregular pupil that's increasing in size, so-called blown pupil. But don't be fooled. There's a false localizing sign where this could actually happen on the contralateral side of the lesion, and this is due more to Roper's theory of lateral displacement of the brain down in the contralateral third nerve, causing that pupil to blow. So pupillary size and reactivity, asymmetric pupils are very important to look at. Coma can progress, start out with stupor, which just means a decreased responsiveness, or coma by a neurologist means total unresponsiveness to any type stimuli. Coma, according to the Glasgow Coma Scale, is anything less than 8. So it's different if you're a trauma surgeon versus neurologist, your definition of coma. It's very important if you have a comatose patient and you think that they might have an ischemic stroke in the brainstem, that you make sure the patient is not in a locked-in state. Locked-in state can sometimes be difficult to differentiate from coma, but oftentimes in the patients that I've seen, you can establish upward movement, eyes moving up and down to command, so you know that someone is awake. You can establish communication with that person. I'm always very worried about a comatose patient that I don't have an etiology for, and make sure that they're not in a locked-in state. Getting back to pupils again a little bit, pinpoint pupils tend to imply a pontine lesion, often a pontine stroke. And then the actual eye movements, conjugate lateral deviation can be caused by several processes and usually involves a destructive frontal eye field. So if you have a right hemispheric stroke, you destroy the right frontal eye field and the left frontal eye field, pushing the eyes over to the right. So you're looking away from the side of the hemiparesis. In contrast, frontal eye fields are activated when you have a seizure, so you're actually looking towards the ictus, or where that seizure is from. So-called wrong way eyes with thalamic hemorrhage can be either towards or away from the lesion. And often with thalamic hemorrhages, the eyes are deviated downward. Skew deviation can occur with an infarct somewhere in the brainstem. And so you look for disconjugate eyes with displacement of one eye downward compared to the other, or upward, depending on which side is affected. Ocular bobbing was first described by Miller Fisher and describes brisk conjugate downward movement of the eyes with a slow drift upwards. So often thought of as a bob, a fishing lure, so it bobs down quickly and drifts back up. And then absent of oculocephalic and oculovestibular reflexes are suggestive of massive ischemic or hemorrhagic brainstem strokes and possible brain death. I'd like to talk about some scoring system. So we talked about the scales used for coma. The Glasgow Coma Score, or GCS, is commonly used to assess patients. And again, the score is a 3 to 15. There's a ceiling effect of GCS, so you could have hemiparesis and still score a perfect 15 on GCS. A better scoring system is provided by Dr. Vajic's and the company, which is the 4-score system, which is the full outline of unresponsiveness. The 4-score assesses 4 things, and it assesses eye response, motor response, brainstem reflexes, and respiration. This testing can be done in minutes, and the inter-rater reliability has been shown to be very good with this scoring system, and we use this, and I think it's very, very helpful. We talk about testing. Laboratory testing is important if there's a metabolic cause. Electrolytes, liver function testing, ammonia, blood cell counts, ABG, thyroid function tests, vitamin levels, culture tox screens, alcohol level, and in the workup include things such as lumbar puncture, neuroimaging, and EEG. Again, the non-contrast scan can be very helpful for lesions, but MRI, as we know, is more sensitive, and in particular looking at anoxic ischemic brain injury, or acute demyelination, strokes, punctate hemorrhages, abscess, empyemas, meningitis, encephalitis, ventriculitis, or tumors. And the DWI imaging with MRI can also be useful. and identifying etiology for coma, but has a relatively low yield. If we're looking for vascular cause, such as a vascular artery occlusion, your vascular imaging, MRA with gadolinium, CT angiography, conventional angiogram, very useful. And we use EEG on almost all of these patients. Let's talk about management of the comatose patient, sort of finish up. All comatose patients require intubation. Using non-invasive positive pressure ventilation is never appropriate for these patients. You have to be careful during the intubation process to avoid cervical spine injury. Hypotension is commonly seen in these patients. So it may require us putting the patient in a Trendelenburg position, bolusing fluids, and occasional vasopressors need to be used to keep the mean arterial pressure greater than 65 millimeters of mercury. Blood transfusions can be considered when the hemoglobin is less than 7 grams per deciliter. This number is based on the trauma literature, and it's been adopted by NCS. Hypertension can also be treated in these patients. Betalol is a very nice drug, either in push or continuous infusion, 10 to 20 milligrams, and the infusion of calcium channel blockers such as nicardipine and clobidipine can be used. And really, between labetalol and either nicardipine and clobidipine, you can control blood pressure. You can use hydralazine. There's been some older literature to suggest that increases ICP, but that never really bore out. Or enalapril can also be used every 6 hours. Key here, obviously, is to find what the cause of the coma is. So a structural lesion needs to be followed. Does it need to be neurosurgically decompressed? Do you need to treat a tumor with lots of edema with steroids? This can be initiated. But clearly, if there's an infectious source, such as meningitis, you can start the antibiotics even before the LP is done, or CT scan. Encephalitis, beginning acyclovir while you're starting your workup can also be initiated. Any suspicion for increased intracranial pressure, it's good to elevate the head of bed greater than 30 degrees. Hyperventilation is in the chapter, and we tend to use that last. I would say that the next step would be, I've identified a mass lesion, the neurosurgery team needs to be consulted. You can use hyperosmolar therapy with mannitol boluses, never as a continuous infusion. You don't want to develop idiogenic osmols osms inside the mass lesion, which will, once you stop the mannitol, will have a contrary effect of bringing water into the brain. And you can also give hypertonic saline, either as 23.4% boluses, which can be very effective, or as a 3% saline or 7% saline infusion. At our hospital, the person needs a central line for 3% or above. But you do what you have to do. The patient needs continuous hypertonic saline. They should get a central line. Edema, again, around a neoplasm, can be treated with dexamethasone. ICP monitoring, an external ventricular device or EVD is really the best thing to be able to do, to use to monitor ICP and to treat it. And then from a systemic standpoint, you can get acute brain injury can lead to cardiopulmonary injury, so-called blast theory of neurogenic cardiac or neurogenic lung injury. So-called Takotsubo's cardiomyopathy is from catecholamine surge at the time of the brain injury. And initially, the echo can be quite abnormal, but normalizes pretty quickly within a short period of time. You can certainly get EKG changes. There's some common EKG, subarachnoid hemorrhage and aneurysmal bleed, and these all need to be attended to. Ventilated patients, you need to have minimal tidal volumes of less than 6 milliliters per kilogram, with oxygenation at FiO2 of less than 0.8, and PEEP can be used, and higher PEEP levels greater than 5 centimeters of water can theoretically impair venous drainage and raise ICP. You would be monitoring ICP and adjusting and looking at your ventilator settings accordingly. Spontaneous breathing trials are important to see those patients that could be extubated. The ostomy placement of the patient is ventilator dependent, just like if nutrition is given via an NG tube and you're not able to swallow, a true comatose patient or patient who has decreased level of consciousness, you have to think about inserting a gastrostomy tube. The nice sugar study, looking at what is the optimal glucose levels in ICU patients, have picked the level 140 to 180. Too strict is not good, and it was shown in that study. So the range is given here. DVT prophylaxis is also important. And then all the rest of the care of a comatose patient is important. Let's talk about outcomes after coma. Again, I'm going to shove here in just a few minutes. The improvements usually from coma are from metabolic or traumatic causes rather than structural brain lesions. The somatosensory evoked potentials can be very useful, but absent bilateral N20 responses on the SSEPs are usually associated with poor outcome in patients with coma following cardiac arrest. However, recent evidence has shown that burst suppression seen on EEG in comatose patients after cardiac arrest, previously thought to be a marker of poor outcome, may actually represent an intrinsic mechanism to rescue neurons from cell death. So burst suppression in recent days, in the recent past, is thought to be a marker of non-recovery, but that isn't quite exactly true. So you may have patients that have burst suppression and recover. It's important to assess brainstem involvement with any patient and be on the lookout for progression to brain death. In a coma for more than 10 days, then we'll say more like 2 to 4 weeks, and they progressed into what's called a vegetative state. It's an old term, more correctly referred to as unresponsive wakefulness syndrome, or UWS is a more current term. But it's marked by intermittent eye opening with no awareness of self or environment. Often there's yawning. Sometimes there's actually movement, but it's not purposeful. An EEG for these patients may show pronounced but diffuse distributed posterior rhythms of delta and theta activity, or spindle and alpha-like activity, but no reactivity to light, sound, or noxious stimuli. That have been in this unresponsive wakefulness syndrome for 3 months are considered, or at 3 months after non-traumatic injury, or 12 months after traumatic brain injury, the diagnosis of persistent vegetative, or UWS, is made. And usually there's little hope after that point for recovery. There's lots of stories in the tabloids and media. A patient wakes up from a coma after 10 years. Terribly, more hepatic or metabolic type causes of coma. And so where there was a reversibility to it. And again, these are not followed strictly by neurologists doing an exam on a daily basis. So we don't really know the history of those particular patients. Functional MRI can be helpful as well. And minimal conscious state can become a state where you could come out of a coma-like state and go to a minimal conscious state. Lots of literature published on that. I suggest you read up on it, because it's a whole hot topic area of maybe these patients can actually improve to wakefulness. I think that in the diagnosis of brain death, which I'll finish with, you have to obviously make sure you know the cause of the coma. There has to be a clear cause, and the patient has to be devoid of other contributory factors such as severe hypothermia, hypotension, drug intoxication, or any kind of medication on board where you measure levels has to be within a normal range. Neuromuscular blocking agents have to be ruled out. Electrolyte acid-base endocrinological imbalance needs to be screened for. And then again, when you're the determination of brain death is absent or brainstem, all brainstem reflexes. And I just suggest you go and look at what's the American Academy of Neurology, and everybody's familiar with this, I'm sure, of what the components are, brain death examination. Next step, if you've declared someone brain dead, is do the apnea test. And the patient should be pre-oxygenated with 100% FiO2 to decrease the risk of desaturation during a test. Sometimes some of the literature suggests this decreases the incidence of arrhythmias, where you'd have to put the patient back on the ventilator. Disconnect from the ventilator, you provide oxygen, flow rate of 4 to 6 liters per minute, and you wait 8 to 10 minutes. You observe for spontaneous breathing. You get a blood gas. The blood gas you can get before you do the apnea test, and try to adjust it to get the PCO2 around normal. But if you don't have that opportunity, the post-test arterial blood gas, PCO2, has to rise by 20 millimeters above baseline or above 60 millimeters. This may be dependent on your hospital's brain death criteria, but that's in general what's required. Ancillary tests, again, are not needed. Really, the clinical exam and the apnea test are all you need to declare someone brain dead. There are exceptional cases with facial trauma where you're not able to assess brainstem reflexes, or other exceptions where you might have to get some type of brain blood flow imaging, either a nuclear scan or a conventional angiogram or EEG monitoring, TCD. Again, these are not the end-all to be-all testing transcranial Doppler because you've not found flow. Perhaps you've not been able to insunate the correct vessel. So that has to be taken with some caution. Lack of blood flow and TCD, but these are all ancillary tests that can be used. So I hope I've gone through this chapter and kind of answered any questions you might have. It's very important to just be diligent with your exam and attend to all the systemic issues that accompany a comatose patient. And as neurointensivists, we're aggressive. We want to do everything we can to have that patient somehow recover from the brain injury and do the best they can. So that's all I have to say, and hope you enjoy reading the chapter.